My talk is about IMT. I'm going to begin it by showing you what the evidence is on corticosteroid monotherapy. And the bottom line is that visual function deteriorates progressively in patients receiving corticosteroid monotherapy. Period. End of story regarding steroid-only treatment of birdshot. I think that this man is owed an enormous debt of gratitude because of his courage. I don't know him. I've never met Jim Folk, but I admire him greatly for having the courage to go public with the experience of their patients at the University of Iowa who had birdshot and were treated with steroids and were followed for long periods of time. I don't know why he did this. I have a little tiny sneaking suspicion of why he did this, and I think it's because of something that Al Vitale and I did. Al Vitale and I had published prior to 2002 our experience with using cyclosporin in the care of patients with birdshot. I think that that was seen widely as being a little reckless. It's just an eye disease. Why are you poisoning these people with chemotherapy? Now, frankly, we weren't the first to do it. Somebody else in this room was the first to do that, and I'll tell you more of that story later. But why not steroids? We're all familiar with them. They work well. Let's take a look at our collection of birdshot patients over the long pull on steroid therapy. So 19 patients were identified. Follow-up was out to 220 months on the longest patient. 7 of them were followed for more than 5 years, and the initial acuity was 20/50 or better in 36 of 38 eyes. Visual acuity was worse than that in 3 of 22 eyes followed for more than 30 months. Visual field data demonstrated progressive loss of area for various size targets that were being used for testing the visual field in 6 of the 7 patients who were followed for greater than 5 years. So, emphasizes 2 things. Number one, maybe that's not too bad with respect to visual acuity. Nonetheless, there is some deterioration. But look at what's happening with the visual field. And what about the electricity? Multiple ERGs were performed over time on 8 of the 19 patients. 7 of those demonstrated progressive loss of retinal function. He concludes, retinal function in birdshot retinochoroiditis deteriorated progressively over a period of years despite stable visual acuity. Late in the course of the disease, acuity may be lost due to chororetinal atrophy. Visual acuity alone is not an adequate parameter with which to monitor disease activity and may falsely suggest that a patient is stable or doing well. Spectacular insight from this study that they did, and it's embarrassing. I mean, to go public with poor outcomes takes a hell of a lot of courage on the part of a doctor. You don't like to publish such stuff and say, you know, have the world look at that and say, boy, they didn't do very well with their patients, did they? He points out, maybe even grudgingly, I don't know, other treatment strategies such as immunosuppressive treatment should be investigated for patients with birdshot retinochoroidopathy. Now, once Folk ended up in print with this, other groups around America in particular took note of that and suddenly got busy looking at their patient populations. Here is from Europe. This group from Belgium went public 2 years later, looking at their patients who were followed on corticosteroid monotherapy, some up to a period of 20 years. Retinal alterations progressed despite steroid therapy. Vision dropped. Visual fields and color vision alterations appeared, and the patients complained of night blindness. Rothova, Aniki Rothova, spectacularly clever doctor, brilliant really, in Holland. She rounds up all of her charts and looks at them and publishes in 2004 long-term manifestations in visual prognosis. What did she find? 55 patients followed for 5 years on steroid therapy alone. Loss of vision was gradual. The number of affected eyes with vision less than 2,200 increased from 9 of 108 eyes at outset to 30% by 5 years and 40% by 10 years. Corticosteroid monotherapy and birdshot, progressive loss of vision. No difference in annual loss of vision was observed between those patients who received nothing and those patients who received prednisone. Johns Hopkins, Jennifer Thorne and Associates, a year later, they round up all their birdshot patients and take a look at long-term outcomes. What they found was exactly what you've just heard presented. Those patients on corticosteroid monotherapy had progressive deterioration. I won't go through the details. You have it in your handout. Use of immunosuppressive drug therapy was associated with a reduced risk of vision loss. Now, here's the culprit. Here is the criminal who is blamed for first using cyclosporin in somebody with birdshot retinochoroidopathy. This French criminal was almost put in the Bastille for having done this. But you'll also notice that when Al Vitale and I did our work with cyclosporin, we were completely ignorant of this publication. We thought we were making new discoveries. And why were we ignorant of it? Well, it wasn't because we can't read French, but because Dr. Luong had the amazingly bad judgment to publish in transplantation proceedings. Now, who the hell reads that? But you'll notice that his work preceded ours by several years, treating 21 patients with birdshot who had had steroid therapy before, other drugs as well, and cyclosporin was then brought onto the battlefield, producing a dramatic regression in retinal vasculitis, improvement of visual fields, and ERG electricity. Emphasis: cyclosporin must be begun early before permanent damage. Vitale and I made the same observations, and we really thought that we were onto something and published on this matter in 1994. The problem was, after we published on this collection of 20, well, I'm not sure how many patients, but after we published on this collection of patients, my idea in treating patients, almost always, is not to depend on drug forever. I have the firm belief that if one artificially controls an autoimmune problem for a sufficiently sustained period, the immune system has the capacity to relearn how to autoregulate, whether that's because of generation of new regulatory T cells or what, I don't know, but this has been shown in disease after disease after disease, including autoimmune ocular disease. So I'm trying to take cyclosporin away in my patients, and I can't do it. The attempts to taper are associated with flares, and so I was then hooked on cyclosporin. Fuchs came forward in 2000 and published on another group of patients treated in a different way. Maybe this is the holy grail. Intravenous immunoglobulin, or IVIG, every month, infusions, long follow-ups. Most of the patients improved or stabilized, and 20 eyes had a marked improvement in visual field. Now, this therapy is amazingly tedious and amazingly expensive, and it's not popular. It is FDA approved for certain diseases, but not for uveitis, not for birdshot. And we can't do it in our clinic. This has to be farmed out to some other group or some other doctor. I think the French have a better system for such collaboration and IG therapy, but you simply need to know that here's another option. And actually, I was talking with a new birdshot patient yesterday about this maybe being the better option for her care. We did a long-term follow-up study and published in '05 on patients with birdshot using non-steroid-based therapy, namely IMT. There were 28 patients. Notice that the drugs that I used then, cyclosporin, Cellcept, Imuran, methotrexate, and this beauty, which doesn't exist anymore, teclistamab, it was a varied collection. I'm struggling. I'm trying to find my way, trying to find the holy grail that will put a stop to it all, cure it, and allow me to tiptoe away with no medicine in the picture at all. The conclusion of this publication, long-term preservation of visual function is attainable with IMT. Prompt treatment should be the order of the day. That really does offer the best hope for maintaining retinal function in what is often thought of as a chronically progressive disease resistant to treatment. Becker, in association with the group in Portland, published in '05 on 11 patients, retrospective review. 5 received IMT, 6 received only steroid. The 5 receiving IMT all did well, stabilized or improved. That group. I'm showing you different groups coming to the same conclusion. We believe that it supports the use of non-corticosteroid immunosuppressive therapy in a subset of patients with birdshot. My group, again, in '08, using this incredibly beautiful drug, teclistamab. It's mostly used in the transplant world to salvage a rejecting kidney transplant. Unfortunately, a cheaper version of it came out, and the company that was making this stopped making it available. There is some hope that it will make a comeback by the by. But it was incredibly effective at stopping the progressive damage in patients with birdshot. And Niki Rothova used methotrexate in her patients with birdshot, or at least in some of her patients with birdshot. Her conclusions: early therapy with immunosuppressive therapy is superior. Methotrexate is better than no therapy. Methotrexate is better than corticosteroid therapy. And finally, this is our latest publication. One of the authors with my group in the fellow is here at this meeting today. And it looks at the cocktail of combination cyclosporin A and Cellcept. 49 patients, retinal vasculitis effectively treated. The ERG 30 Hertz implicit time improved from baseline. Vision was preserved. And notice that this was long-term stuff. These were not short-term outcomes studies. But notice also the problem I alluded to earlier, and that is getting the message out to the masses of retinal doctors around the world. Please, please don't hold on to birdshot patients, treating them only with systemic corticosteroid. Now, I want to just close by showing you one of the many obstacles that we have to struggle with, and by we I mean all the doctors here. When we submitted this paper, you submit it, they send it out to reviewers, the reviewers anonymously critique it, and then they send it back to you, and you're supposed to respond to the critiques. And sometimes they're helpful recommendations, and sometimes there are things that one might object to. So I just wanted to show you 2 things that reviewer number 2 said. I believe that there is lack of evidence to state that this technique can represent a startup therapy for birdshot. And why should I use 2 drugs rather than 1, increasing the risk of side effects? I won't show you what I wanted to say back. My response was, the reviewer is absolutely incorrect in his or her belief that employment of 2 separate drugs is more risky, more dangerous than employment of monotherapy. The increased safety and effectiveness of a 2 complementary drug strategy is well proven and is exactly the reason why transplant surgeons employ the model always in order to prevent transplant rejection. 2 separate pathways to control the immune system, 2 separate possible side effect profiles so that one's not piling on and increasing risk. Lower dose of each drug compared to what one would be required with monotherapy. Reviewer 2 also said the conclusions seem to put the steroids as a marginal part of therapy, which is not exactly correct. Foster's response, actually, this is exactly the point that we're trying to make. Corticosteroids represent a very poor choice in the care of patients with birdshot and should categorically be marginalized in the long-term care of patients with this chronic disease. The editor accepted all that instantly, and the publication was out in print. I think I'm probably running over time, and so I'll stop. You have this stuff in your packet of handout material about the use of Remicade in treating birdshot, and also this, which addresses the matter of can corticosteroids actually work against one? It seems that patients who have never had steroids do better than patients who have had steroids. So the bottom line, the immune system can relearn how to behave properly. It can learn not to attack patient tissues. Pemphigoid is curable. We have huge numbers of patients off therapy, 20 years, pemphigoid, never a recurrence. Childhood uveitis is curable, birdshot is curable, and so are many other autoimmune diseases. Thanks very much, folks.